So this is the part one of our 3-day boot camp on biomedical informatics, and this is the light stuff. This is just to kind of give you a fun flavor of BMI and clinical informatics. And this slide somehow doesn't seem to be coming through with my words on it, but what I remember it said is, what is clinical informatics and why do I care? So these are some of the things that even those of you in the room who are not clinical informatics, I think it's important because you're in the department to understand the flip side of some of the things that are going on. Those of you who are working specifically on imaging informatics, high-end computing, all of those things, it doesn't hurt to know what the other half is doing. And one of the main roles in hospitals today for clinical informatics is a relatively new position, which is the CMIO, or Chief Medical Information Officer. Generally, CMIOs are physicians. They can be nurses, but they are usually physicians who are essentially almost full-time working at the interface of the electronic health record, the health systems, and providers, nurses, and patients to make sure that there is appropriate deployment and use of the EMR. And as any of you know who's worked with the EMR, it's really a nightmare much of the time. There are terrible glitches, problems, nothing works. There's alert fatigue. Every 30 seconds there's another pop-up. You try to get to something, you can't get to it. And so in theory, we have an unbelievable tool, which is an electronic capture of everything. However, we all know that we're not there yet. In radiology, when I do a biopsy, there are about 6 or 7 pieces of paper that I have to fill out. I have to do the checklist, I have to do a whole bunch of stuff, the consent forms, all of that. And then I can't dictate the case till the tech has filled out all of that and filled out their own drawings of what they saw. And then that's all scanned in and uploaded into the computer. So it's completely inaccessible to anybody who ever wants to look at it. It's there, however, if they want to sue you, they can find that and print it out. So it's not like you don't have to do it, but it's a blob. It's completely, it takes text blob. It's unsearchable. It's completely lost information. So we're not there yet. Now, at the end of this today, I think you will be able to define what is informatics. And you've already heard today a lot about clinical informatics versus the rest of informatics. Some of you, Dr. Kelly is our CMIO here, and Matt is the Associate CMIO for Stony Brook Medicine. And we all want to know what Matt has to learn in order to have his job, because you all might want his job someday. So the genesis of this lecture series is really the Informatics Board exam. It is, as you've heard this morning, a subspecialty now approved by the American, the ACGME, and it's offered through preventive medicine and through pathology. It's the same exam. But it's a difficult thing to define what is informatics, and there's different points of view. And I put these names up there, not for those of you who are not sitting the exam, but for those of you who are going to be taking the exam, it's important to understand, to know that there are different points of view, and these are probably some things you ought to read about. Now, speaking of reading, we have put together a reading list for you, which we're going to be circulating after the class with live links, so that you can go back and read about some topics if you're interested. We don't have it ready now because we wanted to have your email so that we could send it, because a piece of paper is really kind of silly. Now, introducing the department here, if you go outside the door when you're finished, is a poster. And you can see this is a lot of what you've learned already today, but we've got a lot of collaborative faculty across the institution. Dr. Harrington in radiology, Mark Henry, these are all people that when this theoretical center is formed, most likely will form the core faculty. We have 3 board-certified clinical informaticians or biomedical informaticians at Stony Brook, Joel Saltz, Laura Falkman, and Jerry Kelly. So we're beginning that. All being well, Matt and I are going to be sitting the exam in the fall, so that's a little pressure on us that we need to study, because you all will know if we failed. So we've got to sit the exam. This department's major focus in research, pure research, is the pathology imaging informatics. But we're expanding now into radiology imaging informatics and taking that information, integrating it with genetic information, and coming up with what we think and hope will be phenotypes of different sorts of patients. Population health informatics, a very, very important part of clinical informatics, actually. Not really clinical, it's slightly different. And we were very involved in that here in this department, a baptism of fire, because I don't think any of us had a great deal of experience. Janos did, absolutely did, but the rest of us were new and had to put together something rather impressive for the DISRIP effort. And that was quite a challenge, because as we'll learn later, data is a simple concept, but not always so easy to quantify. Now, what is our department? We had a retreat a year and a half ago now, I think. And I think I'd revise this today. This is what we came up with as what is biomedical informatics here at Stony Brook. And it's an interesting department. We should know that we have 1 foot in the medical center and another foot in the College of Engineering. It's not just a medical center department, so that we have really amazing people like Dai Fang and Fu Shang who are really doing, and Jonas has got his feet everywhere. He's more like an octopus. But people who are doing very, very important work that's much more computer intensive, mathematical, all of that stuff, and we have the health sciences side. And so here we have our tree wrapped by our administrative support. And we thought that what was important to our department was data, obviously, data visualization in the cloud computing, education, population health and quality, integrity, and empathy, loyalty. We kind of like each other quite a bit and work very well together. And I think that that's a very important part of this, is teamwork. Teamwork is absolutely essential for success in biomedical informatics. Now, when you look at clinical informatics, where are we? We're right at the center of the health system, the intersection of the health system, information technology or IT, and clinical care. And where those 3 things come together, there sits clinical informatics. Now, going backward just a little bit in time, there was no such thing as a board certification in informatics. And AMIA, which is the American Medical Informatics Association, put together a white paper on what is informatics, clinical informatics, what is biomedical informatics, and what on earth do you need to know? What is the core material? If you learn that, you would be considered an informatician. And Ed Shortlift, there's a book out there that you might want to take a look at and just, browse. Ed Shortlift was a sort of big guy in the field. That's his textbook. Les Leonard. I mean, these are all people that I've come to know over the years. And so they said, we've got to figure this out. We've got to write down what it is that we all agree on are the core tenets of what is this discipline. And they said, and it was interesting that Dr. Kashansky also read aloud a definition. And I'll tell you, it's interesting, because I was sitting with Joel at a fellows meeting. And I kind of snuck in because I'm not a fellow, but they let me in anyway. And there was a big round table of the, grand poobahs in the field. And they said, well, what is it that we do? And each person was sort of mumbled. They couldn't quite get it out. And really the idea was to work on the elevator speech because it's a very difficult concept to figure out. And so they said that it is the interdisciplinary field that studies and pursues the effective use of biomedical data, information, and knowledge for scientific inquiry, problem solving, and decision making, motivated by efforts to improve human health. Data's in there. That's very important. Scientific. You've got to solve a problem and make people better. So it's not, as Joel said, it's not about the algorithm. That's part of it. But it's about the whole process of using data and algorithms and support and tools and data visualization to improve human health. Now here, you can see, this is taken from that white paper, that you have varying scales from molecules, or in the case of pathology imaging informatics, nuclei. You've got from nuclei, below that genetic information, so you've got a huge scale from you can't see it, to populations and societies, and it involves that entire spectrum. Basic research to applied research and practice. These guys over here are helping the department with a lot of basic research. Eleanor is doing applied research and practice. Kimberly is doing applied research and practice. And it's all biomedical informatics, it's all clinical informatics, really, in some sense. But the clinical informatics really focuses more on the more practical, the more applied, readmissions, sensors, that sort of thing. Informatics and translational science is also important. And here, I think Joel would be very pleased to see that in 2012, bioinformatics and imaging informatics was a core piece of what is informatics. So what we're going to try and cover today are some of the things, this was the core content as determined by that august group of people who said this is what you need to know for the test. So this is, for those of us who were taking the test, this is what we need to know for the test. And you can see that leadership, team building, communication, all of those things are part of the core curriculum, the core material that you need to know in order to become a board certified informaticist. And again, it's an interplay between academia, healthcare, and the community out there, not just all of us here at an academic institution, but to drive change beyond the walls of Stony Brook and beyond the walls of Columbia and some of the places that are really very well known for informatics. And in the middle, here we are. This is us today. Education, experience, synergies, people, ideas, software. We're here together to drive research and change in the community. And it's, again, a continuum from basic to applied research. And this is really what we're all about. It's about taking all of the collective brain power in this room and turning it into something that's going to drive change. Computer science. That Joel came to biomedical informatics from computer science, and after medical school decided that he really couldn't do it. He didn't want to go into clinical medicine. He wanted nothing to do with it whatsoever, and fled to aerospace. And he worked at NASA for a while. He was faculty at Yale in computer science, nothing to do with medicine. But what's really interesting is that all of those techniques and all of that learning is applied equally well to medicine. It's just another domain It could be oil drilling. It can be fracking. It's the same techniques. So what makes it biomedical informatics is that you take those techniques and you think about how to apply them to answering and solving a real clinical problem. Now, there are different areas of informatics, and I thought that, you've heard this already a bunch of times today, so I won't belabor it. But clinical informatics, they're not just doctors. There's nursing, there's dental informatics. Really, there can be anything that uses this methodology to drive change and support better health care delivery is informatics. Here, we are developing, actually, Kathy Collard is one of our first PhD enrollees in the department, and she's going to be pursuing her PhD. She's a nursing informaticist in the IT department. And public health informatics, we have worked very closely with the Department of, not department, but the School of Public Health here. It's not, is it a school now? I think it is, yes. School of Public Health to develop public health informatics, bioinformatics, and molecular, cellular, and organ systems, and then imaging informatics. And I think that these two kind of make a single whole. They interdigitate quite a bit. Now, Jonas just left, but Jonas' tool, which, as I said, I was loath to show you, but if we have time later, I can pull it up and we can look at it live. But it won the best prize of the AMIA most recent conference. The Stony Brook won. Yes, we did, and it was a team effort to deliver something. It's a demonstration tool. But it's to deliver something that will allow interactive exploration of genomic, radiomic, and pathomic data. So it's very, very interesting, and it's not one person, it's a whole team. Now, again, the pathomics, I thought I would touch on very briefly. You saw this is because it is a major focus of the research of the department. Everybody who comes to the department, and many of you may not come back for a second day after you've suffered through one day, but this is the pathomic work that's being done, and you're looking at different clustering. It's quite mathematical, it's quite technical, but nonetheless, it's something that those of you who are interested in a more less clinical point of view could be potentially interested in. I doubt it, because I think most of the people here who are from outside the department are here because it's clinical informatics. And this is radiomics. And what is that? You should at least know what it is. And some of you may and some of you may not. But say you have a CAT scan. Okay, every cancer patient pretty much has a CAT scan. Say they have lung cancer. Okay, so they have a CT of the lung. Is there information in the tumor, hidden in plain sight, beyond what the radiologist can see, that will inform more about that patient's illness, possible response to treatment? And can you predict from looking at that CT scan or MR scan what you might find if you were to biopsy that? For example, patient comes in with a lung cancer, it's biopsy proven, they receive treatment. Now, can you tell something about that new, it's a smaller tumor now, but do you know if that tumor is going to get bigger all of a sudden and metastasize? Or is it really cured? And so the idea is you do mathematical analysis of the tumors or whatever you want on a CT scan or an MR, any image, and then do standard image and feature analysis to get a lot of different features, things that are mathematically based. You know, how much difference is there between one pixel and another over a certain space? That kind of thing can tell you perhaps that it's very heterogeneous or it's very homogeneous, and therefore give you some clue as to the biological behavior of that tumor. So that's what radiomics is, and the intersection of radiomics and pathomics is mission critical. But getting back to clinical informatics, there are different competencies needed. And here today, this is sort of what we want to talk about a little later in the day, the management and social sciences piece of this. Because if you can't communicate change and advocate for change and create change, all of the stuff that you do is completely wasted and lost. And change is hard. Institutional change is extremely hard. And as an informaticist, you need to create change. You need to convince the organization that you can help them, and you need funding to help them. So it's a whole skill set that's extremely, extremely important. Project management, all of those things that you wouldn't think have anything to do with biomedical informatics or clinical informatics all come into play. Now, as Joel was saying, you can get to being an informatician from different backgrounds. Healthcare professionals, biologists, computer scientists, health IT, information science. As a matter of fact, Andrew White, who I miss very sorely, was a librarian, and he was very instrumental in the department here. So it's many, many disciplines to create a team. Now, what isn't informatics? It's not a lot of things, but it is where the intersection of information science, computer science, cognitive science, and application come together. And the application can vary. It can be clinical, it can be readmissions, it can be defining the population of the county, it can be helping the cancer center. That's one of the things we're doing now, is what is, as going for NCI designation, what constitutes the catchment area for Stony Brook Cancer Center? Well, how do you know that? Well, you can't just kind of go out and ask at Stop and Shop, excuse me. So there's all kinds of information available and data that you can bring in to make these decisions, and that's informatics. And the idea is that a human brain plus a computer, you can tell that's an old slide, because I haven't seen a computer that looks like that for decades, is better than either alone. And so trying to get away from the idea that informatics is anything done using a computer, health information management, people tinkering with computers. It isn't, and this is something too that I would like to deliver to the audience when you leave today, to have a better idea a little bit of what we do. Now, this is a man I've never had the pleasure of meeting, but really very interesting, and it also shows you that good ideas do not derive solely from academic centers, that there's a lot of good medicine practiced elsewhere. And Dr. Collin was recruited to Kaiser Permanente in its early days and was one of the pioneers in collecting medical data about patients on computers and creating large data sets that could be interrogated. And it was under his jurisdiction that the first really decision support tools were developed. And apparently somebody came, this was the New York Times obituary, somebody came to see him in the 1960s. And it was a congressman. And that day, the patient had an abnormal white count. And so, really abnormal. And the computer suggested, consider leukemia. And the patient came back and had leukemia. And apparently this shot was heard around the world and was heard in Washington. And it was the first time that the thought that a computer could diagnose medical illness was really entertained. And I guess it was good for him because he died at age 100 in 2014. So he did well. But it's really very interesting because he was not a full professor at Harvard. He was a doctor who had to solve a problem. And how do you solve a problem? How do you keep track of all these patients across Kaiser Permanente? And so he employed very early computer techniques. And here, this is funny because his father was my mother's professor at Duke. His father was chair of medicine at Duke, and my mother came actually as junior faculty from Ireland under Dr. Stead Sr. And then Dr. Stead Sr. was still at Duke when I was there. But his son is a luminary in clinical informatics, and worked with Ed Hammond, who they're both very active still, and Ed Hammond was a PhD. And so you see the idea is really a clinician and a PhD together make a very, very strong team. And I think that that's what we have in this department. And I think it's really important to take advantage of that and to leverage that. Now, talk a little bit about the history of informatics. It's been around for a while. It's been referred to by different people. And this is the famous Joel's article from Perceptions and Knowledge of Medical Students Regarding Computer Applications in Medicine. So that's from 1985. At that time, Duke was really quite ahead of the curve. We had computer terminals on every floor with an operator who did nothing but order things on the computer, got lab results on the computer. She sat at a terminal, and that was really unheard of in 1980. That was really unusual. So there were a lot of systems that were developed in informatics, a lot of homebrew systems that are no longer in use, but were the fundamental basis for many of the systems. The MUMPS, is MUMPS there? I don't see it. The MUMPS language was the basis of EPIC. And here, just to say, what are we using today? These are the EHR systems that we have in use today. We have Cerner, and that's what we have here. And you can see that there are many other, but EPIC and Meditech are two of the others. And here we have a little bit more about the CMIO, which I think if you have any questions, you can ask Matt about that. These are the skills that are needed. Now, this is something I'm going to run through in the last few minutes that I have of a CMIO survey over the years, which was done by a national survey company, 95 CMIOs. And it's very interesting, these word clouds that show you in 2008, what were CMIOs thinking about? Quality, liaison, change, leadership. 2013, change management, challenging, analytics. See, Jaja Analytics, that's 2013. It's now coming into the forefront of what's on the mind of the CMIO. 2014, meaningful use. Analytics, optimization, challenging, strategy, interoperability. So now 2015, population health is huge because we're now going from a patient-centered model to a population-centered model of improving the health across the population. And then here, very important, primum non nocere, first do no harm. In 1999, the Institute of Medicine was shocked. I think they were shocked to find, and the public was shocked to find, that more people died of medical errors in hospitals than of AIDS, motor vehicle accidents, and breast cancer. And a medical error is defined as failure of a planned action to be completed or the use of a wrong plan to achieve an aim. And the cost to the United States for medical errors in 1999 was somewhere between $17 and $29 billion. So the thought was, we've got to do something about this. This is not okay. So in 2001, they came up with a follow-up publication and said, you know, really, guys, we've got to do this differently. We've got to re-engineer how we deliver healthcare and change the environment. And here, this is where clinical informatics comes in, applying evidence to healthcare delivery. using information technology. These are all from the Institute of Medicine in 2001. Aligning payment policies with quality improvement and preparing the workforce. And then just one last thing that I think has really changed a lot of how we look at quality and how, not look at quality, but what tools do we use to achieve quality. And Atul Gawande really hit a spot in a lot of ways, a sort of a sore spot, saying, you know, other industries do better than medicine. Planes don't fall out of the air with a great commonality. I mean, what do pilots do differently? Why do skyscrapers not fall down? And a lot of the people in the room read this book for our retreat, but it really swept the whole country by storm, and changed a little bit about what we did. And here, and this, I won't spend a lot of time on this, but you should look at our poster outside. This was our plan to drive data quality improvement here, because if you analyze garbage, you get garbage out. If you don't understand when something comes out that, gee, that doesn't look right, maybe there was a mistake in the query, maybe we're calling things incorrectly, then you get garbage. So we developed an entire quality improvement plan and process to look at how we manage data. And you can't read this, the poster's out there. And so with that, I think I'll finish. I just wanted to tell you this is a very important journal in the field. We will give you all a reading list of things that you might want to look at further, but I just wanted to introduce the topic and thank you.
And my name's Ed Kalpis. I'm a preventive medicine resident, and I got involved with this from my work with BMI, but I'm also the chapter leader for the Institute of Healthcare Improvement here at Stony Brook. The IHI is an international organization that has chapters all over the world, and there's a chapter here. And I got involved by taking some of IHI's classes in quality improvement and leadership and things like that, community involvement, and then became a faculty advisor, and then later became the chapter leader. So if you're interested in healthcare improvement, quality improvement, using data to improve healthcare, we're always looking for people that want to be involved. There's opportunities to become faculty advisors, get involved in all different ways to mostly education of medical students, residents, faculty. Really the aim is to educate as many people as possible around improving healthcare. So my talk is going to be on quality improvement, and this ties in very closely with informatics analysis and using these measures to see, are we getting better? Are things staying the same? Are we getting worse? So this is an introductory lecture on quality improvement, so you get some of the basics, some of the fundamental tenets of quality improvement. We'll mostly focus on Pdsa Cycles. Has anyone heard of those before? Pdsa Cycles? Yeah. Anyone know what name those are associated with? What's that? Yeah, you count. No, but someone's name. There's a person. Who invented this? Does anyone know? So very close. Actually, they're called Deming Cycles, but it was actually his mentor that developed him, Walter Schuhart, and that was at Bell Laboratories, so the famous Bell Laboratories. Deming gets credit for it, but it was actually his boss and mentor that developed them, and then he sort of took it and ran with it. So you might hear the term Deming Cycles. You might also hear Plan, Do, Check Act. Those are along the same lines, but these were popularized by Deming. So we're going to go in depth into these cycles. We'll touch briefly on Six Sigma and Lean, some of the other commonly used methodologies for quality improvement in healthcare, but we'll focus on Pdsa Cycles. And we'll talk about some examples that IHI was involved with. So most of these cases were taken from IHI. They work with all different types of organizations, from Saudi Arabia, like we'll see, to Canada, to the United States. And then we'll also have an opportunity to use this model for improvement, and we'll develop a project for your own life that you'd like to improve something. So start thinking about one area of your life where you'd like to improve something in your life.
What was your project for those?
I haven't done a specific project with them. I've just been involved with outreach and creating educational opportunities for them. So really, we've reached out to other IHI organizations on Long Island to create a collaborative so we can work together to develop educational opportunities. So let's talk about one specific example, central line infections. So does everyone here know what a central line is?
No, I don't think they do.
So oftentimes when people are in the hospital and they're quite sick, they might need IV access. That's like a more permanent type IV access. So it goes into a big vein, either in their groin, in their neck, in their shoulder, and this can help with their health care. One of the problems, though, is these can often become infected, either because they're not placed properly under sterile techniques or they're not monitored properly. So this is a big problem that over 30,000 types of these infections happen every year, also called collapses. And one scenario is the IHI was working with this group of hospitals in Saudi Arabia, and they were working specifically in their neonatal ICU, intensive care unit. And they were having about 11 catheter-related infections per 1,000 catheter days, which is fairly high. So they created a project to decrease these infections. And we'll look at some of the concepts of quality improvement and how they use these concepts, and then think about an area of your life where you'd like to work on improvement. So whether your goal is to reduce central line infections or your daily life, these tenets are the same. So take a minute and think about an area of your life you want to work on. Maybe you want to sleep more, or maybe it's eat healthier. So think of an area you want to work on. Make it not too personal, because I might ask you to share what it is. You don't have to share, but if you want to, I'll ask you to. Okay? So just take a minute and think of something that you want to work on. Anyone want to share the area that they're going to work on? Yuri? Sleep. Awesome. Anyone else? What's that? Eat less candy? Awesome. Anyone else? Yep.
Be able to wear my pre-pregnancy clothes.
Pre-pregnancy clothes. Awesome. All right. So there's three critical elements for systems improvement. One is will. You have to have the will to improve. Without the will, nothing's going to happen. Next, you have to have some ideas. Right? What are some other ways we can do this? So if I'm sleeping X number of hours, I need some ideas of how I'm going to sleep more. And then finally, you need the execution. It has to be something that becomes real in your life or in the hospital. So IHI's developed what's called the model for improvement. So there's three questions you ask first, and then you go into this Pdsa cycle here. So plan, do, study, act, and this goes around in a circle like this here. So first you do these questions, and then into here, and we'll go more in depth into this model for improvement. So these cycles give us, yep. This is from IHI.
Is there a paper that is from?
There could be a paper associated. I'd have to look at the exact reference. So at the top of that graph is three questions. First is, what are you trying to accomplish? And that gets to your aim. Next, we want to know if a change is an improvement. So you want to establish your measures. Is this getting better, staying the same, or getting worse? And then what change can we make that is going to result in this improvement? So this is going to be the changes that you test in that Pdsa cycle. So this might seem like an esoteric thing right now, but we do Pdsa cycles every day. Maybe, you ate breakfast this morning instead of skipping it like I usually do, and hey, that worked out pretty good. Or, I took the train to class this morning rather than ride the bus, And oh no, it took a little bit longer on the train and it was more expensive. Oh, that didn't work out so great. Or instead of writing out my hand notes in class, I tried to type it on my laptop. Oh man, I'm such a slow typer, I missed like half the things that they were talking about. That was a total disaster. So we do these, little PDSA experiments every day. We're always looking at things on how to improve them. So those are just some everyday examples. But you first want to set an aim. It could be, will improve our infection rate isn't good enough. That's very vague and broad. You want to make it time specific. So like by when are you going to make this improvement? And exactly what are you going to do? Like how good, by when, for whom. So it has to be specific. Next, you're going to establish your measures. So you need feedback, right, to know, is this working or is this not working? Are we staying the same or getting better? Then you're going to identify changes. So how are we going to achieve this aim? Where are we going to get these new ideas from? So a little bit later, after lunch, we'll talk about some sources of brainstorming. And, how do I get some ideas to improve things? Then you're going to test the changes. This is where those Pdsa cycles comes in. You're going to test something, try it, plan it, observe it, act on it, and you progressively get better and better. We'll show a graphic a little bit later as you sort of climb up this hill of improvement. And then finally, you're going to implement the change where once you've had successful changes, you're then going to implement them system-wide. So that's going to become the new standard process in a certain setting. All right, so before we get into this specific example in Saudi Arabia, the food's here. So we're going to actually take our lunch break now. So let's see. We'll come back at 1:30. So you'll have an hour break to eat, and then come back at 1:30. We'll restart with the quality improvement lecture, and we'll go from there. Okay? So thank you.
Thanks.
Great. Thank you. So we're going to continue our lecture from before lunch. And so remember, we were talking about reducing catheter-associated blood infections in the neonatal ICU in a group of hospitals. And so they created an interdisciplinary team that included the head neonatologist, the charge nurse, a data collection clerk, infection control coordinator, and the quality improvement coordinator. So it's very important to have interdisciplinary teams to work together in these quality improvement projects. So the first thing they did was set an aim, and their aim was to decrease the infection rate from 11 infections per 1,000 catheter days to less than 5 infections per 1,000 catheter days over a period of 9 months. So as you can see, it's measurable as well as time-based, and those are two important parts of your aim. Next, establish measures. So they're measuring the outcome, which is how often they were doing the prevention things at the checklist that we'll talk about here shortly. So not only the checklist, but also how often did these bloodstream infections happen. So we'll talk about the difference between those two types of outcomes in a moment. Next, they identified the changes they were going to make. So the first was a bundle of different interventions that reduced the rate of infections. It was things like hand washing, checking the central line daily to make sure there's no signs of infection, as well as a checklist anytime they were inserting the catheters. That included making sure that they were properly draping the patient, sterile procedures, things like that. And then finally, they placed red tags on the beds of all the babies that had central lines, so it's easily identifiable. You can see from across the ICU that this baby has a central line, so you can pay special attention to that. So those were the three things that they thought maybe would make a difference. Next, they tested the changes. So remember the Pdsa cycles that we talked about? So they did several iterations of these Pdsa cycles to see what worked, what didn't work, and you learn from each cycle and build upon the previous knowledge. So this is something called a run chart. So it goes over time, and then you have your specific outcomes on this axis here. So in this case, we're looking at two different outcomes. One is compliance with the checklist. That's the line in blue there. And then the orange line is the compliance with the bundle. So we're looking at two different outcomes. These are what are called process measures. So we're looking at different things that are being done that we hypothesize will make a difference in the outcome, which is the line infections, right? But we're saying, okay, this is the percentage of the times that we're using the checklists or using the bundles. So you can sort of think of it as like an intermediary step to get to the outcome. Then next, here's a second run chart, once again over time, where here they're looking at the infection rate, and it goes up, it goes down, and here's their goal rate, they're actually the median rate. And the thing that you can do with the run chart is measure when you did these different interventions. Okay, this is when we implemented the checklist. This is where we implemented the bundle. And you do these iterative cycles where you see, does it go up, does it go down? And then eventually they decided, hey, this seems to be working pretty well. Let's institute these as a ICU-wide policy. So the overall strategy is you try something, it works, it doesn't work, okay, you try something else, you build on that, you learn. So this is a process that you go through many different ideas, different cycles. And once you've come up with a new policy, you start training everyone, it becomes part of the fabric of the culture. And in fact, in this case, they spread it not only from the neonatal ICU into the pediatric intensive care unit as well. So it was a successful intervention that they're then able to implement more broadly in these hospitals. So that's just one example of a healthcare Pdsa cycle implementation. Like I mentioned before, there's two other big types of quality improvement frameworks that are used frequently in healthcare. I'm just going to touch on these briefly. We'll go more in depth in session, the second boot camp, on these specific ways to implement these, but just so you get a sense of these different frameworks. One is called Six Sigma, and Six Sigma, based on the idea of reducing defects. So it started from manufacturing, and the Six Sigma means less than 3.4 defects per million. So that's where the sigma comes from. It's a statistical measure of the number of defects. Like 1 sigma is like, I think, 600,000 errors per million, and then it goes down, increasing the sigma level. So pretty obvious that we're not very often going to get down to 3.4 errors per million in healthcare, but we can still use the framework that was developed in manufacturing to guide us in our processes in healthcare. You might have heard of black belts and things like that running around the hospital. I don't think we have a lot here, but other hospitals, there's different levels. There's like a green belt, there's the black belt, and you can get trained inside of this methodology in healthcare specifically, where you define the problem, you measure the defects, then you analyze the conditions, improve by testing, and then control your results by determining what's going to maintain that performance. So in some ways, it's not really critical which framework you use, but it really helps to have a framework that you can use. It guides you, and you can continue to iterate. The other framework is Lean, and Lean focuses more on the customer's point of view, where you're improving the value, and you identify value streams, you look at the product flow, you're creating what's called pull throughout the system, and you manage towards perfection. So you're, once again, continuously improving the processes. So that's just another framework you might have heard of that we'll talk about more in depth in bootcamp number 2. So next we're going to talk about why it's important to set your aim statement and then identify the key elements of an aim statement. And then we'll continue to develop your own personal improvement project that we talked about. So if you weren't here this morning, we all picked an area of our life that we'd like to do a practice personal improvement project. And let's see, Yuri, I think you said you want to do sleep. Yeah. Someone wanted to cut down on candy. Who was that? You, Matt? Who else shared?
Pre-pregnancy clothes.
Pre-pregnancy clothes. So if you haven't come up with a project, just think of an area that you'd like to work on. So the aim statement is going to answer the first question in that model of improvement. What are we trying to accomplish? It's going to say, how good do you want it to get, by when, and for whom or what system is this improvement going to be based on? So not so useful statements: will do better on tests, I will lose weight, I'm going to exercise more often. Why are those statements not so good? Not measurable. What else? Not time-based, right? By when are you going to lose that weight? How much are you going to lose, right? So those are not very helpful aim statements. Here's some better example. Every member of our study group will increase their grade point average by 10% within 8 months. Or I will weigh 160 pounds or less by February 1st. Or I'm going to run at least 10 miles per week by July 4th. So
it's very interesting. When I was at Emory and Bill Bornstein, I talked about him earlier, they were in everybody, I think everyone in the room has heard of UHC rankings, which is now Pdsa. And at the time, Emory was like Stony Brook in the middle of the pack. And Bill Bornstein would stand up, and he had assembled a team of quality people, interdisciplinary from across the hospitals, of about 60 people, nurses, doctors, a lot of people. And he stood up there, and every time he said, we will be in the top decile in the UHC rankings in 5 years. And it seemed impossible, because it wasn't that Emory was doing well, but it was exactly that. It was this much progress by this time. And it set a high bar. And then really it was quite effective. Because every time he said it, I thought it was ridiculous. And I sat there and I thought, this is just silly. And by God, the entire institution did it. They did it, and they set that goal, and they achieved it. So I think there's a lot actually of value to this.
Yeah, thanks for putting that in.
Yeah.
So now let's all take a couple minutes and create a specific aim statement for your own project. So just take a few moments, think about what you specifically, maybe write it down for yourself, like what is your specific aim, and then I'll ask a few of you to share what you're creating. Does someone want to share what they wrote? Matt, do you have something?
I would try to stay away from people who have
What?
So would you say that's an effective aim statement?
No, she's only trying to begin with.
Very good.
All the time, and there's always candy, which is not. I'm going to remove all candy from BMI 5. I will limit it to 3 Twix a day. Okay.
By when?
By next week.
Yeah, so that would be an effective aim statement, right? Maybe not, your outcome might not be that great depending on what your outcome is.
Or where you started.
Yeah, maybe you're starting from 22 Twix per day, so that would be quite an improvement. But yeah, so that would be, an effective aim statement in that you're giving a specific outcome over a specific amount of time. Someone else want to? Yeah.
I will submit my manuscript to Journal of Pain by June 30th.
Great.
Today.
June 30th. Fourth revision.
Great. Anyone else? Yuri?
I will sleep 6 hours a night the next 2 weeks and then 7 hours a night thereafter.
Great.
Sleep, but how can you force yourself back there?
Oh.
We'll get to that, right? The Pdsa Cycles here. Yeah. Very good. So now we've talked briefly about the 3 types of measures, and we'll list and talk about the differences between quality improvement versus research, which is something that often gets collapsed together, particularly in academic institutions. And then we'll talk about displaying data, and then we'll develop some effective measures for our own personal improvement projects here. So getting where you're at now, we call that the baseline. That's the current performance. And then we're going to come up with ideas to improve the process. Then we test the changes to see if that actually led to improvement or not. And then we're going to ensure that those improvements that are effective are maintained over time. So quality improvement on the right is different than research. So a lot of us are used to doing research where we're trying to find statistical significance in one main hypothesis, and we're trying to control for all the biases so that we have a valid study. But in quality improvement, we're more aiming for sustained improvement over time versus proving something's effective. In quality improvement, we want to just gather enough data to inform our improvement. We're not authoritatively proving something like you're trying to in a research study. In research, you have one large test with a fixed hypothesis, and you're trying to control bias, versus quality improvement, you're just trying to keep the bias equal throughout the different iterations. And then finally, the results. With research, you're doing a pre and post test, versus quality improvement, it's a continuous reevaluation. Like you saw those run charts, you're measuring every month or you're measuring every day, and things go up, things go down, versus research is a totally different methodology. And so sometimes it's difficult for us to switch mindset from this research mindset that, oh, I got to prove this is like the right way, versus doing these small changes, and then you see if it gets better, it gets worse, and continue to make iterations. Yes. Sure.
So in research, though, you can have an adaptive study design, which is more similar to what you're talking about for quality.
Sure, absolutely. Yeah, you can make some changes, but it's still a different mindset than quality, where you're really constantly updating everything.
This does not have to be statistically significant. There is no, it just has to look a little better, that you're trending in the right direction. And that's a very hard thing for scientists to get their head around. That, well, it looks better, but how do I actually prove that washing your hands helps? Well, maybe you don't in this particular moment. It just seems to be related. There's no causality. It's a common sense approach. Like if I beat the eggs a little longer, will the souffle be lighter? Or if I overbeat it, what's going to happen? But you're not really proving that 36 beats to a certain consistency is going to give you the best souffle. So it's a very difficult thing when you're talking to doctors in particular. They don't want to do this. This is stupid. It's not scientific.
Gary.
Right, so I would say, when you're doing quality improvement, you don't have to try to establish necessarily, but the evidence that you're using that what you're doing is working should come from research, right? If I understand correctly. Like, you're not trying to show statistical significance, but if...
Well, you are measuring. You are measuring, you still collect data, but I wouldn't call it research.
No, I'm not saying you're doing research.
But you're saying that you're not going to say, well, we're going to start pouring dirt on wounds. Because after all, there has to be some scientific basis for the,
I know what you're getting at.
Yeah.
So if you are going to do hand washing, and so use your example, so you're going to keep changing the process until people wash their hands enough, right? So that's your outcome, is to get people to wash their hands. But if you look at the data from the hospital, you can track the change in infection rates before, during, and once you've finalized a protocol. That's the run chart.
Yeah, and that's indicating both the process, right? Washing your hands, that's the process outcome versus the the outcome that you're looking for is
Not
decreased
necessarily
infection.
research, but it's showing an outcome that you could rely on.
So, I mean, the point I was making was sort of even broader than that, and that is, we know from research evidence that hand washing is effective at reducing infections. Because of that, we're going to implement this project that will help increase hand washing.
Yeah.
We're not right. So that's what I mean. Like whatever you're
So
doing,
yeah.
like what the processes that you're tracking, the intervention, those should themselves be supported as really being the things that will change the outcome you're trying to change. But in the quality improvement project itself, you're not going to try to prove that it works. You're already assuming that it works based on prior research. Right.
And there's a lot of quality improvement projects, like we'll see improving flow through the ER. There might not be any empirical research out there that says, hey, you should do this first, and you should do this in your hallway to improve flow through this. So there might not be any evidence on certain quality improvement things. Improving flow through a radiology department. There was probably not an RCT that tested that at your hospital, right? So a lot of times in these quality projects, there might not be any empirical evidence out there, and you might have to.
Your whole configuration is different from someone else.
Right.
So, yeah.
So there might not be any evidence to base it off. So.
You're trying to get most effective, the short distance in a way, flow mapping.
Yeah. So I mean, there can be still, hypotheses and things that you're working off of, but it might not be necessarily based off, some scientific RCT or something like that. But yeah, you're not going to do something that's totally crazy, like, hey, let's try, IV bleach on every patient to clean out these central lines or something, right?
Well, I mean, it doesn't have to be that crazy, but it could be something that other people have tried, but research has shown does not work. But you don't want to implement that either. It does have to be crazy.
Right. If you wanted to do that, you'd have to do a research study to say, I still believe that was a flawed study and it really should help. But that's not this.
Okay.
I think the ethos of the Deming cycle is in its application, which is why it's so important for you to finish the open school. You have to apply it to a project. So it's only as good as what you try to do. That's why Plan Do study act in its application. So if you haven't done a project, how can you do quality?
Yeah, it's totally real world, like based in something in action in a clinic, a hospital. It's all like real world, totally.
Yeah, but in some way there is an essence of prior work done on this. So if you've identified the problem is workflow or transition of patients from ER to the floor, we want to improve that because we have so much time. You would get your team together and sit down and talk about barriers that are preventing that. And one might be communication, or one might, there's a background that says communication can be a barrier. There's a background that says systems design can be a barrier, but really you're getting some information before you go figure out what you're going to do. You're not willy-nilly going out there and saying, we'll try anything.
Sure.
Right, and then I think Ed's next point is absolutely important. You try it and say your team is absolutely convinced that the problem is that the nurses all need iPads because that would just fix it.
And there could even be an RCT out there that shows, hey, you get an iPad and your infection rate goes down by 50%, but then you try that in our hospital and it doesn't work for some reason. We're not going to say, oh, the RCT proved that this works if it doesn't work in your particular setting. Maybe for whatever reason there's, resistance to using that at this hospital or whatever. you're going to use the evidence that you collect in your facility about these different things. So it's an iterative learning process that is totally real world, like Kim's pointing to. It really, that's where the rubber meets the road, and you're going to learn from your specific Pdsa cycles. So if something's not working, you try adjusting it. You're going to accept that there's bias in the data, and you do your best to maintain that bias equally. You're not trying to control for everything. You're just seeing how things change over time. And then ideally, you use data that someone else is already collecting that's going to facilitate these rapid turnovers instead of having to develop a new measure, a new survey, a new something to collect the data. If you can use something that's already being measured, like these infection rates, then you can facilitate these rapid turnovers. So we've talked about briefly these different types of outcome measures. So there's the outcome measure, like we said, the infection rate. The process measures would be something like following a checklist, hand washing rates, things like that, that you're suspecting will impact your outcome. Anyone know what a balancing measure is? So when you do some of these tests, you might see a certain measure go down, but maybe some other measure goes up that you didn't expect. Like maybe now there's all these rashes that are happening because you use this new soap that the nurses are now washing their hands with, and now this rate of dermatitis goes up. There's this other negative, unintended association that you might not have expected. So sometimes you want to collect data outside of the specific outcome you're looking for, and that's called the balancing measure.
But it can also be two good things that happen, right?
It could be.
That you could be doing something, and because you're doing it, there's an overflow now to some other process. That because you're washing your hands, maybe now you're doing something else as well that now impacts another outcome.
Yeah. Could be some related, but something that you didn't expect maybe, or something that you need to see, hey, how is it? Now we need more doctors because we're so much more effective, something like that. So we've sort of briefly talked about this, but let's say that you are in the emergency room and you're trying to improve the wait times for the patient. Maybe your specific aim is to reduce the wait time to 30 minutes by next November, so it's time-based and specific. And for a few months, your team's tried different changes and gathered data on several different process measures and outcome measures and seen what the average wait time in the ER is. So here's another run chart where they were starting out above 35 minutes, then it went up. So they tried one intervention, they tried huddles, and that seemed to have things go down a little bit. And then over time, things seemed to come back up again. Then the nurses started early. Then they made some changes to the lab procedures. Then they moved their patients into the room as soon as possible. And overall, there's a downward trend. So you're not showing statistical significance that this specific thing made a difference, but you're trending the data over time to see, is this overall making an improvement? Has anyone created one of these run charts before? There's actually a tool on the IHI website. If you want to make one, they have like a format that you can use to make these very easily. It's quite helpful. So any questions on run charts, outcome measures, process measures, balancing measures? So next, there's 5 approaches you can use to come up with some of these ideas of change and some other change concepts that can help facilitate things as well. And now we're going to identify some changes for your own personal improvement project. So you can think about the current system. How are we actually doing things now? That might be mapping things out, the exact flow, what's exactly going on. You could use benchmarking. Technology can also be something that can enable change. Maybe it is those iPads. Maybe it's creative thinking, or using some of these change concepts that we'll go over. So maybe it's eliminating waste, improving workflow, optimizing inventory, enhancing the producer-customer relationship, changing the work environment, managing your time, managing variation, designing systems to prevent errors, and focusing on the design of products and services. So think about your own personal project now. So you can use some of these ideas here. Maybe it's critical thinking, technology. Maybe you're using your Fitbit. Think of some ideas of what you can use to implement in your own personal project here. You can use some of these ideas here or some of these. So just take a few moments, think about what are some changes that you can test through Pdsa Cycles. Anyone have any ideas? Was that?
Combination of
But what specifically in your project?
You always need to think critically about the current system. Some people would rather not, but that's important. Benchmarking, how you're going to know where you're going if you don't know where you were and where you want to go. What's the benchmark, the yardstick. Using technology can facilitate because you have better. The computer can crunch the numbers and make graphs, creative thinking. Sometimes you need to think your way out of a situation because the way, Einstein said, well, the way you got yourself into this mess is not the same way of thinking to get yourself out of the mess. Using change concepts, I'm not sure what number 5 is.
That would be some of these here. One of these 9 uses it.
Oh, yeah. Okay.
So what about specifically, do you have a project that you thought of?
Yeah, the ever so famous losing weight.
So what are some different things that you could think about here?
Well, I remember in the past, number 1 was actually number 1. I had to actually look at what I was doing and saying, I'm definitely taking in too many calories, and I got to do something about this, either to take in less or increase movement or a combination of both. Benchmarking, of course, if benchmarking, by that you mean the 2 strategies we talked about before, it needs to be quantitative and time, chronological, then you can't go off willy-nilly saying, well, I really need to lose some weight, this happening, that happening, whatever.
And maybe actually finding out how many calories you're taking in each day.
Exactly.
How much exercise are you doing per day? How many calories are you burning?
Right, and sometimes you can't do that without technology unless you get a ton of books out of the library to find out, how much is, each activity or work.
Right, so that could the technology could facilitate, measurement of the data. You get an app on your phone or you have a Fitbit that can track how much exercise you're getting. Great. All right, thanks for sharing. Thank you. Anyone else want to talk about their specific project and maybe what you saw from these techniques here? Anyone else? Yuri? Any ideas on your sleep project?
I guess creative thinking is always a possibility. I'm not sure if using change concepts. Are you going to cover
These
that?
ones here, these are the 9 change concepts. So maybe you...
Then definitely, yes. I can see that. Also, managing my time better, for example.
So how could you do that? What could you use here to help improve that?
What could I use? I think just the change concept of managing my time better itself would be useful. So just finding ways to maybe not be on the computer so much so that I can actually cut an hour of computer time and then add that to my sleep time.
That's eliminating waste.
And is there anything you could use here that might facilitate that, or anything in this list here?
Besides eliminating waste and managing time, maybe change your work environment. So put the iPad away at a certain time. Try not to go back to it or something. I can think of some things.
Set a reminder.
Set a reminder, right?
On your iPad?
No. Just shut it off. Right? Why not?
Shut me off now.
On the watch. Yeah, exactly. They talk to each other anyway.
Great. So these are, some techniques that can help you think of ideas. These are mostly designed for, a business setting, but you can use these also in your personal projects as well. So here are some healthcare examples. eliminating multiple entry that can be facilitated with the electronic medical record. I know in employee health where we still have paper charts, you got to write things down like 8 times in different places, and that's having an EHR would definitely streamline that. Reducing controls on the system. So for instance, in a smoking cessation clinic, if you let the team determine who was going to do the counseling, maybe in one clinic the nurse is better, another clinic maybe the doctor is better at doing the counseling, or maybe you have some other person that specifically would be best at that. You could have some flexibility built into the system to allow them to determine who can do that job best. So that's in the reducing controls bucket. Maybe it's recycling or reusing something where, for instance, some X-ray techs found that they were wasting the canisters that contain the X-ray film, and they persuaded a producer of the film to let them recycle those for refills. Or maybe you use substitution where, some certain places you might have to handwrite a consult to doctors, and you could create a system where you do that in a computer where you're already in the EHR. Luckily, I think we have that here at our system. Something called reducing classification. So if you have like 22 different appointment types, a patient might have to wait, months to get a specific type of appointment, versus if you reduce the number of types of appointments, that might facilitate things and make it easier for the doctors as well as the patients. Another concept is removing intermediaries, where in one project they identified 31 different steps involved in transferring a patient from the ER to the inpatient unit, and they bypassed some of these steps by having the clerk directly call the admitting clerk. Matching the amount of time to the need, using sampling, changing targets. So there's lots of different techniques you can use, and we can go more in depth in this in the following boot camp, but there's lots of different frameworks and techniques that you can use, whether it's materials, methods, environment, equipment, people, and things like that. So my time's up, but hopefully this gave you some ideas of things you can think of, and you got a little bit of a taste of using this on your own project. To just think about how can I make a specific aim, what different techniques can I use to come up with ideas, new ideas, creative ideas, and maybe bring some of those ideas to your work as well. Hey, how can we implement these Pdsa cycles? That's a different sort of way of thinking than traditional research.
So I was asked to talk about some of the raw material for work in this biomedical informatics. I'm talking about data sources. So a lot of us are interested in what happens here at Stony Brook Medicine. So we want to, depending which department we're in or which area we're in.
That was pretty photographed. I know. Why did you use that one?
Huh?
It's pretty.
What?
It is what it is.
It is what it is, right? But, so we're interested in what's happening within Stony Brook Medicine's wall or even outside of Stony Brook Medicine's wall. And so I just want to start here that what are some of the data sources that we can work with. So this is also, I have a graph from the Meaningful Use Office of Health Information Technology. What this shows is that for hospitals, right, the percentages with electronic health records, I mean, it's nearly, if you look across, right, and probably even more today, nearly 100%, right? So information is being captured digitally at almost every hospital, and I think in the outpatient setting, the numbers are a little bit lower, but on the outpatient setting, it'll approach 100% too. I mean, probably like 5 or 6 years ago, when you would give this talk, you'd probably say, you'd have to probably talk about why electronic health records have advantages, but I really don't see people going back to paper. I think we have the system we have, and we have to make it better, but we're not going to go back to paper. So more and more information is being captured electronically, and how do we make use of that electronic information? So I'm going to focus now a little bit on what's happening here at Stony Brook. We use a Cerner Millennium, which is one of the major electronic health record vendors. So if you're giving clinical care in the hospital using Millennium on a say, daily or hourly basis, and that's the main system where data is being entered into. But as we look across the healthcare system, we find there's different subsystems within that larger system. And if you want to connect all the data together into like a single database, then we need to like integrate data across multiple databases. And I think it's been now, 3 or 4 years, we've been working with Cerner on Healthy Intent, which is Cerner's platform for data integration across multiple different databases. So we're using it at Stony Brook to integrate data across the system, from some of the cardiology systems to Southampton, to Eastern Long Island, to our billing system. It's all being integrated into a sort of a single record that's being maintained by Cerner. And that's what we call like Healthy Intent or Healthy DW. So what is Healthy EDW? It's a system that sort of integrates data across multiple platforms. It's big data, data transformations. So you can see here we have claims data, which is administrative billing data, which is very useful. Clinical data, which is data being captured electronically. Wellness. We want patient satisfaction, social and public data. That's all going through sort of like a pipeline that's processing the data. I'm not going to talk too much about sort of this pipeline, but there's a process which the data sort of flows. And so what we want to do is transform the data through this process into sort of records, longitudinal records, care management dashboards, engagements for community members, and analytics. So we really want to take this data, move it across this process, and produce products which sort of help the system run more efficiently. So, and then we can also have de-identified data. You want to also, create program systems to manage data better. Okay, so let's see. So I'm going to just talk a little bit about sort of in more detail about how we go from electronic health record data into more complicated into data analytics. So if you're familiar with PowerChart, this is a screenshot, right? So this is sort of the system that we work with most, right? We work most with electronic health record systems. They're really designed for data entry, for observing a single patient. And so you can see that this is sort of like the main interface for working with the healthcare data that clinicians work with on a daily basis. So this is sort of like the portal when people talk about electronic health records. This is the portal that people think about using data, about the data. And so I think one of the issues, though, as we face is that the data is in the electronic health record. This is how people see the data. But this is, as we want to utilize this data, we need to think about how that data is abstracted from the system, how it's manipulated to make it useful data, right? So a lot of times people say, well, I see it in PowerChart, but I want to use it in my research study, right? And then we ask them, where'd you see it in PowerChart? And they say, well, I saw it in a note. And then which note? And then, well, it could be in these 4 different notes, right? And so you can see that quickly, mapping the data within PowerChart, even though something is captured electronically, it doesn't mean that we can utilize it in a research study or for quality improvement. Part of the problem, though, is the data is stored. Yeah, the data is stored in an electronic health record. Electronic health record is designed. Basically, electronic health records are designed. The database are designed for putting data in and getting data out about a specific patient, right? So you want to design the system. System design is sort of a transactional system. You want to, pull up a specific patient. You want to get that record for that specific patient and see that data. the other part of the relational, why this database is so complicated is electronic health records have evolved over time. They started off, I think Cerner started off in hospital billing they started? Or lab?
They were labs.
Okay. So they started off in a very specific niche, and then so they then expanded their system to other areas. So if you go actually, this is a nicer, cleaner schema than what we actually see in the Cerner Millennium system, because they've sort of, over time, to support what they've done in the past, they keep adding additional tables and making it a little bit more complicated. So the database itself gets more and more complicated. So now if you look at the Millennium tables, there's thousands of tables. So if you say, I want to get data out of Millennium, you have to kind of search across those thousands of tables to find data and extract it. So that's sometimes when people request a crystal report, and they're like, why does this take 2 weeks or a month, 2 months? It's because it's very time consuming to extract out the data elements from that system. So they, it's they have to look at it, and then they have to compare it how it's in the electronic health record, validate it. So it's a very slow and difficult process. Now, going back to what I showed before about healthy intent data platform, that does simplify getting data out of electronic health record. It's part of it, but we still need to do a little bit more work for that.
But that was the idea.
Yeah. I mean, it helps a lot in that you don't need to know every obscure, go from 1,000 tables to 100 tables. It's better. Okay, so talk about this. Some of the work that we're doing here in biomedical informatics is, the team that I'm working with, we're trying to make the data more accessible, easier to work with, easier to answer questions from. And this is an interesting project called Odyssey, which we're working on in biomedical informatics to map our data in electronic health records into this standardized data format called Odyssey, which maps terms to standardized vocabularies. So here's another example. You get a lab test, right? Or you have a measurement made, and what happens there is that we have internal codes in Millennium. Those internal codes in Millennium are not standard. They've been developed locally. So if you've been at an EHR, if you've been in multiple hospitals, you know that even though we have Cerner, another facility might have Cerner, their Cerner is going to look different than our Cerner because we've put in our own codes, our own drug codes, right? So it's all mismatch data. So one of the things that Odyssey does is standardize to a standard vocabulary set, which makes it easier. If you're familiar with billing data, you're familiar with October 1st, 2015, which was the data that we went from ICD-9, or from ICD-9 to ICD-10, right? So if you're doing analysis across that period, you need to be able to change your analysis now because, well, I was using ICD-9 codes, now I have to use ICD-10 codes. Something like OMAP allows you to standardize data elements so that mapping is consistent across. So just give you a sense of stuff. The schema within OMAP, I mean, still, now we're down to about 20 tables. So we started off with 1,000, went to 100, and in Odyssey, it's about 20 tables. So it's definitely less than what we had before, and it's easier to work with, easier to analyze the data. Second. Yeah. Yeah, so here I just want to show so we have standardized codes. Here, example, they use SNOMED for some of the vocabularies for the diagnostic codes get mapped to SNOMED. Because there's different diagnostic coding for you. If you're ICD-9, ICD-10, you want to map those to a standard or high-level vocabulary. And so they have standard codes for that. People familiar with standard codes? What? The concept of it? Okay. So the idea is that and medicine has quite a few vocabularies that are present in medicine. So, we have things like ICD-9 code, which started back as for measuring for mortality studies. The codes have changed over time to include like diagnoses, also include things like vaccinations. So those are all, and there's a specific code for that. They've been utilized mostly for billing purposes. So if you want to bill for something, you need a diagnostic code, so the insurer can evaluate like was this a proper procedure or not. And so the codes have become very important in medicine because they help standardize the payment. And we have codes here like SNOMED, which was started off, I think, in pathology, and cover across domains. And so this is an example of a standardized coding. So if I map my data here and somebody maps their data in Europe, and we want to compare our studies to each other, if we use standardized coding, we can do that comparison. So that's why standardized coding is important in research and quality. Okay. So one of the things that we want to do actually for research is, we want to go down to one table. So we want to we start with, thousands of tables. We want to go down to one table. And so here's an example that we've been working on is transforming electronic health record data into a format that's more simple. This is where we're looking at sort of laboratory test results or diagnostic codes. We want to look at that in one table to analyze it, because if you're familiar with statistics, you don't analyze statistics on 10 tables. You only analyze it on one table. So really the process that we're sort of the group here is working on is how do we move data from the sort of higher dimension of multiple tables to a data set that we can use for analysis. So here's another example of, talk a little about this use case example that we have in BMI. So, we have internal data, right, that we can map down to, let's say, lower dimensional structures. But we also have other data sets that we can work with. And here's an interesting example. This is HealthFacts database, which is another database of electronic health records. I'll talk about Sparks in a second. But it's a anonymized database from multiple facilities in the United States where the patient, we don't know who the patient is, we don't know what the facility is, but we have a record of their care through electronic health record. We have been using HealthFacts here for a couple different research projects, from one on looking at in surgery. We also use it for building models. And so in this example here, we're using it to build a simple predictive model, whether a patient has heart failure or not. And so this is, we're using it, we're building it against, we don't know which facility we're building it against, but we can build a model, test it, and see how that model works. So that's a database called HealthFacts. We have a protocol that people can apply to work with that data set through SWEDUG, which is the surgical quality project. So any questions on the databases? Okay. I also want to talk a little bit, this is not my main focus area, but, we have, so far I've been talking about what's called discrete elements. So this is when I said that, when I asked somebody, is this an electronic health record? And they say, yes, it is. It could be a scanned PDF. It could be, it could be a note, or it could be what's called a discrete element, like a laboratory test measurement, where we know the type of the value it is. And so there's a lot of data in electronic health record, and we're sort of at the start of this. That is in natural language. How do we utilize that natural language? How do we analyze it? That's an area called NLP. I just wanted to bring it up to say that we can deal with it. It's difficult and time consuming, and I think this is probably an area where technology is going to improve pretty drastically in the next 5 to 10 years. We have, okay, and then I talked about other types of data sets that we have. So we have electronic health record data in detail. We have it from multiple facilities, so we can compare ourselves to other facilities. But we also want to have contextual data about our communities, right? So this is a data set that's from Census Bureau. This is what's called the ACS, American Community Survey data, which allows us to look at sort of our communities, right? And we can look at geospatial, communities. This is about food stamps. So there's also contextual data that we want to combine with our data that we have in electronic health record system. And this data is available. You can get, there's a site called Fact Finder that you can download this data. Okay, so then, so I thought a little about the difference between administrative data and electronic health record data. So electronic health record data is generated in the care of patients, right? So you're placing an order, you're getting a laboratory test result, right? And it's really focused around, the treatment of the patient, right? Administrative data is focused about sort of how administrative data is focused on how the organization functions, and this data is critical for payment, right? So we provide a service, we want to send that information to the insurer to say, okay, this is the service that we provided, and this is, and they'll evaluate was this a correct service or not. So administrative data is all about sort of, and it's all coded data, and this is sort of the largest source of data that that we have. So we can look very focused at an individual institution and see what's happening, but administrative data allows us to look across multiple institutions. And this is where Sparks comes in. Sparks is, it's not unique. I mean, the type of Sparks data set is not unique to New York, but New York was one of the pioneering states that developed it. So every hospital in New York State has to submit, as part of their licensing, inpatient hospital has to submit a detailed database or record for each patient treated as an inpatient or an ED at the hospital. So, and the state's been collecting this data for now multiple years. So this allows, and this is this is a table that we generated for the DISRIP project, which shows, how we can use this data to sort of have a larger population health perspective on it. But this is, we're looking across multiple facilities in New York State. This is administrative coded data, and it's a little bit level up from the lower level electronic health record data. So we do lose information as we go from the care record up to administrative data, but we can look across multiple facilities, across multiple years, and this has probably been the area where most of public policy health research has been done in terms of healthcare systems. So that's Sparks data. There's a public Sparks data which doesn't provide as much detail, but it's accessible to anybody. And Jonas has built nice tools for working with it. You can answer some pretty interesting questions. Yes.
Look at that, Janos.
Yeah.
There, in terms of the cancer center catchment area,
Yeah.
look at cancer as a primary disease map. Look how many of those patients have psychiatric disorders. I mean,
Yeah.
it's really quite remarkable.
Yeah. I think, I don't remember whether this was just for the Medicaid population or for the entire population.
Yeah, but still,
Yeah.
it's important.
Okay. And then, so this was across New York State. Now the data has been collected through CMS, Medicare. And so as you go up, right, you can start to visualize, and this was the data that Medicare providers in Wyoming, sort of a network graph that I did a couple years ago, which shows how different providers in different cities share patients with each other. And so I just want to show you can start off at the very low level, and then we can start building up to sort of higher level types of analysis. So, and I just want to show that this data, all these pretty connections, right, it's pretty graph, right, if you go down and focus in on something, is really about those individual nodes are providers. So, we can see that we start off with very low level data, right? That's stored in the electronic health record, lots of tables, right? And data keeps moving up. and we keep, extracting the data, and we can start to answer questions across the entire system. And so that, I just wanted to give you a sense of the data landscape in healthcare. So, and the type of data that we deal with in bioinformatics. So that's what I have. I think we're almost in time.
Keep going.
But yeah, but if people have questions, maybe it's better, like, if anyone has questions on.
I would love to go back to that last slide that you showed, and the one, the MGH and the Brigham, the one, this one.
Yeah.
Now, so that shows the referral patterns and a look at for one patient. Now, this is a population.
The population of patients.
So and the General Hospital Corporation, is that the MGH?
Yeah.
I would imagine. And so you've got, like, that's really fascinating. You've got all of these patients bouncing back and forth between the MGH and the Brigham.
Yeah.
Anybody who's been in Boston, that would make a lot of sense. And then between Boston Medical Center is another place, but patients tend to stay within the Hardwick system. That's interesting.
In the previous slide, what is paternalistic?
This was based on the zip code, or actually the city that the person, or is that actually a zip code or city? I don't know. It's been a while, so I have to go back to the block.
That population.
Yeah, so,
Yeah. Provider they do.
This was a pretty good, this was like, this graph was nice because of the way Wyoming is, right? Because Wyoming is separated by, like, each city is like, 3 hours away, right? So the networks tend to be tight. Like, so this is like,
Like one city area.
yeah. But if you look at like Long Island, like New York, Long Island, Connecticut, it's like there everything is sort of like one big graph. Yeah.
Yeah, I had a question for the previous slide with Clark.
Yeah.
What is that collection of diagnosis? Like code from the EHR, like from the medical record?
That's from that was billed, right? So this was the billed diagnostic codes for the inpatient. Yeah.
Okay, so.
Yeah. And yeah. So we talk about like primary, like when a hospital planning, they usually talk about just the primary diagnosis, the primary services, right? And because those primary services is what they get money on. And so it's like if it's going to be, sepsis, that's like the primary thing treating sepsis, or if it was for other things. But in the inpatient setting, what they've done is it's collected a lot of detailed diagnostics, like detail. So usually an average patient has between like 10 or 15 diagnostic codes, and they'll have secondary diagnoses. And so this was analysis of the combination of secondary diagnoses that you could have in, and this was using sparse data. I have to go back to the source of this, but in terms of the...
Interestingly, yeah, one of the things that we sort of came up with in our quality process, and this was before that, was trying to include on every slide exactly where we got the data and where it came from, the data provenance, and over what period of time. And because at the time you make this slide, nothing is clearer in your mind than what is on the slide, and it's really important to document where did you get it so that you can go back and recreate this analysis or answer the question, is this all patients? Is this Medicaid and uninsured? Is it who are these people? And if you go out and look at that poster set at lunch, you can see that we kind of had this problem, and we figured out that it is a problem, and we forget. And so this is really interesting stuff. But right now it would be, rather than Janusz having to go back and look it up, which he can clearly do, it would be nice to say that this is for Medicaid patients collected between 1999 and 2007 across this geographic region. So, because I think this is for Suffolk County probably.
And I think this was included, I think, in the needs assessment. It's probably in the community assessment. There probably is the details on this.
So the systematic capture of metadata, which is essentially what we're talking about. We've got query, data source, the version of the data source is a huge deal. I was at a this is something that's very hard, I think, for small groups to get very good at, especially if you're looking at lots of kinds of data. I think it's something that this broader, as we develop this data analytics for extended group, it's something that's good. And to Mary's point, if we put folks at part of it actually is not really defined, and Andrew White actually is a librarian who is, I think, a leading part of this for a while until this included the RPI came up with a bunch of standards. So tracking is captured metadata. So that's something we need to do. And the other thing, Eric, which we think about in particular, is the issue of a lightweight software infrastructure that essentially keeps track of, yes, these are all the metadata, they're not the metadata. And it's really hard to discipline oneself to remember all of the metadata you're supposed to capture. And I think that Sig left the road as in terms of it's probably good enough to write software that might but I think that's very valuable.
Even we find in daily work that it's kind of confusing because the person who's doing the analysis will say, oh yes, of course, that's the 3 diagnoses we're considering between this month and that month and the ones who had this test. But it's not there, and you can't see that. And so as somebody who didn't just do the analysis, it's not very meaningful. And then the next day you go back and it's slightly changed. And so it really is an important thing because, as I said earlier, there's garbage in and garbage out, and if we don't have a tightly controlled process each step of the way, and I think that's one of the things that, as people who might be interested in the field, and the technical people have a lot of code versions and stuff to worry about, and we all need to understand that. But the very basic idea of what are problems of data, very, very important. And Janos was talking a little bit about one of our projects here that he's been leading is this Odyssey OMA thing. And that came about, it's a common data model. In other words, if it's an avocado in one place and an alligator pear somewhere else, those both map to the same fruit. And so it's very difficult to know that in one country it might be called an alligator pear and we call it an avocado. And Mexico it's an aguacate, and in Chile it's a palta. And so there you have 4 names for the same thing. And it's extremely difficult, and it's conceptually very, very easy. I mean, nobody has any trouble with the concept that a fork should be called a fork. But then when you go into each table, each medical system across multiple institutions, it becomes this Tower of Babel. You can't figure out how to deal with it. And the Odyssey thing, if I am correct in this, Janos, you can help me. What came about because of the need for tracking how devices, implantable devices, did in a patient population. Because patients will have a set for them in one hospital and go to another hospital and then go home and then move to California. And a longitudinal study of how are they doing was important for the FDA and for industry. So industry and Columbia, I believe, partnered together to try and build a way to map alligator pear and avocado to one field, so that you can then do analyses on that data. Because if you're calling something different at each time, and you have to rewrite code each time you do an analysis, you can't get anywhere with anything. And so people say, well, there's this huge richness in this PMR, but you can't get to it. You can't analyze it because it's not a serum creatinine is not the same as a serum creatinine necessarily from another laboratory. There's slight differences in normal values. So dealing with this, and we get outside labs all the time. So does the patient have an abnormal or a normal creatinine? Is it high normal? Is it abnormal? So these are conceptually very, very simple things. But as you may or may not get more involved in informatics, these are very important issues. And we've made a great deal of progress nationally and locally in trying to address some of these things.
And I think also we saw here that when you have multiple people from different perspectives looking at the data, they see different things, and that's a really important. That's why it's like I don't know the clinical practice. I mean, like I was trained as a biologist, so I know from the biology behind things, but I don't know the the clinical practice. So people that are doing the clinical practice see different things in the data than I would see, right? So that's why the interdisciplinary teams are so critical in biomedical informatics, and you learn from each other like every day.
Today we'll be talking about leadership and teamwork, in that order. So when you want to talk about leadership, you want to ask yourself, what does a leader really look like? Does it look like Derek Jeter? Barack Obama? Or maybe it's Gandhi? Or maybe it's Patton? Or maybe it's Selena Gomez? Or maybe it's even Donald Trump? Which one of these people in your eyes is a leader? In many people's eyes, all these people are leaders in some way, shape, or form. Some people look at leaders as this man in red, who's leading his troops in front of the army. Maybe it's the guy in the middle, which everybody's looking to. Or maybe it's the person who's holding your hands in a circle, acting as your equal. Some people look at being a boss and leaders as two different personalities. The boss may be the one who's sitting behind the desk, having everybody else push and pull. Or the leader can be someone who's with their colleagues, pulling along with them. So before we go on to talking about leadership, I think it's important to define leadership. And per the Merriam-Webster dictionary, leadership is the power or ability to lead others, and also the capacity to lead, or the act or instance of leading. When we want to look at leadership, there's a difference between leadership and management. So when we start off looking at management, it usually takes care of control and regulation of resources. They also make sure that the job gets done, and they're more really directly involved with their employees. But then when we switch over to what a leadership does, they really set the vision for the group or the company, and they make sure to empower their employees to get the job done. They set the moral compass and culture for the group, and they also act as team builders. When we want to look at the history of leadership, it really started in 1940 with the Great Man Theory, which basically said that leadership is inherited and not learned. This theory was quickly debunked, and in current day we have multiple behavioral theories, such as the Authoritarian, the Democratic, and the Laissez-faire. In the following slides, we will be going through a handful of leadership styles, which I consider to be prominent and important. This is not a full list of leadership styles, but just a handful of the more prominent ones. When we start with the authoritarian leadership style, we look at the characteristics of this style of leadership. They exert close control over their workforce, and they're really motivated by rules, regulations, and penalties. They take little input from the group, and they believe that people must be compelled to do work. They really use a one-way style of communication, and they're generally poor listeners. Now, this style of leadership has been frowned upon in recent years, but there are pros and cons of this leadership style. The pros include during times of emergency or when decisions are time sensitive and you don't really have time to consult everybody. An authoritarian leadership style really takes a commanding lead. The next one is when work needs to be exact, like in surgeries or in military operations. The authoritarian leadership style tends to work out better. Or also when there's large groups to work with. The downside is that it can create resentment in the long term, and it doesn't support team members to be supportive or creative in their problem solving. The next style that we're going to talk about is the paternalistic leadership. This style is characterized by a dominant authority, which acts like a parent figure, treating their employees in large part like an extended family. They expect loyalty, trust, and obedience from their employees, but in exchange, they are benevolent, compassionate towards their employees, and focus on improving them. They listen to their employees, but ultimately they make their own decisions. The pros of this are in areas where hierarchical structure and little creativity work, and employees appreciate benevolence and work harder to please their bosses. The cons of this style is that there may be perceived favoritism amongst one group over another and cause jealousy and resentment, much like in parenting one child over another. And then also, it's well known that the hierarchical structure formed by this family model is not conducive to crisis management or creativity. The next group that we're going to talk about is the democratic leadership style. This is characterized by an open and collegial way of doing things. They allow ideas to be freely discussed. They facilitate conversations and encourage idea sharing. They synthesize all the information and communicate it back to the group. They really use bidirectional communications to make sure that everybody's ideas and thoughts are heard. And then they delegate out authority to the subordinates to get things done. The pros of this leadership style are that it supports creativity and problem solving, and they also increases group morale. They encourage employee growth and advancement. The cons of this type of leadership style is that basically employees who prefer not to do anything and not get involved won't be involved and won't respond to this leadership style. It's not effective for uneducated or unskilled workforce, and passing the buck seems to be a common failure point for this style of leadership. The next leadership style is laissez-faire leadership, which is characterized by a deliberate abstention from direction or interference, especially with individual freedoms of choice and action. This leader is very hands-off. They allow their employees to make the freedom to have decisions and complete their work as they see fit. They offer assistance and guidance only when asked, and they praise accomplishments and reward success. This type of leadership maximizes the leadership qualities in their own staff because people are empowered to do what they think is right. The pros of this leadership style is it allows experts to be productive and challenges them to take personal responsibility over their tasks. It reinforces successful performance and creativity and autonomy, which subsequently leads to retention. The cons of this is that sometimes there's a lack of accountability, which can lead to failure to achieve your goals. And if the laissez-faire leader is not giving constant feedback on low performance, you will likely not achieve your goals. And with multiple people working on their goals, you can also foster ineffective time management by teams because everybody's working by themselves. The next leadership style will be transformational leadership. Transformational leadership is characterized by really motivating others to do more, by challenging and inspiring their followers with purpose and excitement, being role models. They create a vision to aspire to and they communicate it. They are charismatic and high energy and self-promoting. They encourage thinking outside of the box. They can bring harmony to troubled situations. They focus on long-term goals and emphasize an emphasis which leads to longevity. The cons of this is that it's hard to train a transformational leader. And this leadership style tends to be very self-promoting, and sometimes people can feel manipulated by the transformational leader. And there's also an overdependence on the leadership style in this form. The next style will be the authentic leadership style, which is characterized by an acute self-awareness. They are constantly re-examining their strengths and their weaknesses. They're very relationally transparent. They're open sharers of their thoughts and beliefs. They have a balanced process, meaning they solicit opposing views and they encourage debate, which is very important. And they also have an internalized moral perspective, which is a positive ethical foundation to adhere to by the leader. Authentic leadership is currently a very popular style of leadership. The pros of this style are that they're able to maintain trust and cohesion between a group. They have the ability to create a positive and rewarding relationship, and they tend to promote ethical and moral standards. The cons of this leadership style are that the moral component may not align with the company's goals all the time, and it requires leaders to know themselves very well. And as most people know, that's a hard thing to do. This next portion of our discussion will be on team building. And for all of you who don't know who this is the A-Team, which is from a 1980s TV show in which a group of ex-military men come together to become soldiers of fortune. Now, in this group, each person was markedly different, but they each brought their own talents to the team to complete their missions. So in the next few slides, we're going to go through steps to build the A-Team. So the steps are to first and foremost understand your goal. If you don't know what you're trying to achieve, then building the appropriate team will be hard. Next, you need to establish your own leadership style. I'm hoping from the past few slides, you've realized that there are multiple different leadership styles, and some leadership styles are better adapted to different scenarios. And what many people will say is that you should adopt different leadership styles for different scenarios that you're in. It might be better in a very emergent situation to use the authoritarian leadership style, but then in others, bring in the democratic and the authentic leadership style, or the transformational leadership style. It all depends on your scenario and bringing in different tools to help solve the problems. The next step, number 3, is to be selective in picking your team members. It's important to select a diverse group of people with the appropriate skills. The next thing you need to do as part of picking your teams is don't rely on just your CV. The CV is just the first step in selecting a team member. They also need to focus on your fit for the organization. It's very important that they share some of your goals and beliefs and that they will work well with your other team members. The next step, number 4, is to get to know your team members personally. As part of leading a team, you're going to need to be able to pick up on subtleties of personality. So knowing your team members personally will help you to bridge these problems as they come along. Step number 5 is set roles. People need to know how they fit into the team, and they need to know their responsibilities. So setting expectations and roles for each team member is very important. Step number 6 is to create goals. All teams need short-term goals, long-term goals, and they need to know how they're measured for success. Without these, no progress will be made. The next thing to do, step number 7, is very difficult, is to foster teamwork. To do this, you must set ground rules. You must agree on a time commitment from each of the team members. You must set expectations for each of these team members. You must set the expectation on participation and the process of making decisions, and also for conflict resolution. If you set these ground rules in advance, then when problems do arise, you're going to be able to solve them easier than if you have to make up the rules as you go. It also gives your team members some comfort to know that there are provisions made for conflicts and also to make decisions. The next thing to do is to pay attention to moods and personalities. As a leader of a team, you're going to need to mitigate problems before they explode. And you will need to act as the harmonizing influence to mediate and resolve issues. You'll need to encourage trust and cooperation amongst your team members, because if there is harmony, trust, and cooperation, the team will be able to achieve the goals that you have in mind. And as a team leader, you need to respect everybody's ideas and encourage brainstorming and open speech and respective disagreement. Respective disagreement is a very important point. Most people will shy away from disagreements, but I believe that effective arguing amongst team members is healthy, and it will encourage correct solutions. There's no benefit in having everybody just agree to the first solution, because that means nobody's invested in getting the correct solution. You're better off having disagreements amongst people who are passionate about coming to the best solution and having respectful arguments to come to the best solution rather than the easiest solution without arguing. Communication is the next step, which is very important. It's important as a leader to give frequent feedback and update people on the company's progress or struggles. People are really demotivated when they work in vacuums, and it's important that when someone's doing a job and their work has led to positive things for the company, you need to go back and tell them that, because of your work, these good things have happened. It's also important to relay the opposite. If the company is doing poorly or the team is doing poorly, it's important to circle back with your team and say, we haven't done what we need to do, and come up with plans to mitigate the problem. Step number 9 is to acknowledge and reward. Your employees want to make sure that you're paying attention to the work that they do. And it's not enough to give annual or semi-annual reviews and give people a pat on the back. You should always give acknowledgement when deserved. Step number 10, celebrate success. Always take a moment to reflect and thank your team for any true accomplishments that they have, because that will continue to motivate people to do more. And when you do celebrate success, make the success about the team and not about yourself. And that is one of the true essences of building a team and being a team leader. The end.